Morning, everyone. Good morning, everyone, and welcome to the first program of 2022. As we started this Friday morning session at the very beginning of the pandemic, I never thought that we would be ringing in 2022 and still be in the midst of this this disease. But unfortunately, we have not quite put it behind us. I am very excited about our lineup for 2022, which is taking shape here, and also some of the many changes that we've instituted to start in January here. One of them, as many of you will have noticed already, is that we've migrated to the Zoom platform, which I think will help us tremendously in overcoming some of the technical problems that we've had in the past. In addition, there will be 8 of the popular, very popular institutionally based thyroid tumor boards that's headed up by Dr. Mike Tuttle, who is with us this morning as a panelist. But before we get started, I would like to introduce you to a recently launched THANC Foundation initiative called TIRO. And this very short video will give you an understanding of what TIRO actually is.
Clinical practice guidelines for the management of thyroid nodules and thyroid cancer can be extremely impactful in helping clinicians to better understand contemporary standards of care.
However, accessing guidelines of clinical care can be time-consuming and challenging, which negatively impacts their implementation in the clinical setting.
בנוסף, לאור המספר הגדול של מחקרים המפורסמים באופן שוטף, ההנחיות הנוכחיות נותרות ללא שינוי, ולעיתים הופכות לא מעודכנות זמן קצר לאחר פרסומן.
Often, more recently published guidelines from other countries or societies have more up-to-date recommendations based on recent literature.
TIRO, which stands for Thyroid International Recommendations Online, was developed to overcome the traditional handicaps presented by the existing guidelines. In summary, TIRO is intended to make the delivery of the highest quality of thyroid care available to patients around the globe.
TIRO facilitates the delivery of that care by clinicians, no matter how many thyroid patients they treat.
TIRO is intended to be a resource for clinicians from all specialties, including primary care physicians, who are involved in the initial workup of thyroid nodules and longer-term surveillance.
Great. So in its current iteration, TIRO has the international guidelines for differentiated thyroid cancer. However, that work the work has been completed on both medullary and anaplastic thyroid cancer guidelines, and both of these will be uploaded onto the site over the next month. I hope that you will take the time to visit our site and see how efficiently you can access the latest best practice guidelines for nodule and thyroid cancer management. But most importantly, updates to those guidelines from our weekly educational programs are directly embedded into the site and provided the latest commentary, thereby making these guidelines an extremely dynamic as well as constantly evolving and very efficient way to get information. It is most appropriate that I introduce to you all to TIRO, and at the same time introducing Dr. Bryan Haugen, who is the first author of the 2015 ATA Clinical Practice Guidelines for Thyroid Nodule and Differentiated Thyroid Cancer Guideline. He is the professor of medicine and pathology at the University of Colorado School of Medicine. He is head of the Division of Endocrinology, Metabolism, and Diabetes, and the director of the Thyroid Tumor Program. Dr. Haugen served as president of the ATA in 2012-2013, and was also the recipient of 2 extremely prestigious awards from that organization, the Paul Starr Award and the Sidney Ingbar Award. So thank you, Dr. Haugen, for joining us this morning. And we are also honored to have Dr. Mike Tuttle on the program this morning to help to provide commentary. As always, we encourage all of you as listeners to send in your questions through the question tab, and we will do our best to go to address as many of those as we can by the end of the session, which will be at 9 o'clock. So with that, I welcome Dr. Haugen and thank him for joining us this morning.
Thank you very much, Dr. Erkin, and thanks for the kind invitation to present through the THANC Foundation. This is a real honor for me to be able to talk with folks today. And what I'm going to talk about is this combination of Lenvantinib and Pembrolizumab for patients with advanced thyroid cancer. A lot of work and really focusing on a clinical trial that we've led, and some even preclinical work to sort of talk about these two drugs. My disclosures are that we do receive institutional support from both Eisai and Merck. Eisai makes Lenvantinib and Merck makes Pembrolizumab. This is through the International Thyroid Oncology Group. I do not receive anything directly from these companies. So what I want to do is actually back up and start and talk a little bit about history, because I think that sets the stage for these two drug classes. And I'll talk then a little bit more about each of them and then together. And I think this was a really neat publication and a review in 2020 that talks about intervals between disruptive therapies in oncology. And you can see on the x-axis a timeline here, and then sort of when each innovation peaked and started being used. We can see the original one for cancer, now not just thyroid cancer, was surgery back in the 1800s. And then really it was another 50 to 60 years before the next really disruptive and innovative therapy, external beam radiotherapy, came in right around 1900. Chemotherapy came in the mid-1950s. And then now what we're going to talk about is both targeted therapy and cancer immunotherapy, and they're much more recent that we've seen. So we're also possibly and hopefully increasing our interval between these disruptive therapies to help patients with cancer. So I want to talk first a little bit about targeted therapy, talk a little bit more about cancer immunotherapy, because I think a lot of people maybe aren't as familiar with that, and then talk about the combination therapies. So this is really a wonderful review. I suggest if you're interested in looking at these targeted multi-kinase and even very focused therapies, this is a really nice review by Drs. Fulmer, Cabanillas, and Zaffareo from MD Anderson, and can help set the stage for these targeted therapies. It looks very complicated, but actually it's quite simplified. In the middle is a cancer cell, a thyroid cancer cell. And then you have the microenvironment around it, and it's only represented by two cell types: the endothelial cell, which is a lining cell for the blood vessels and very important, obviously, for nutrients and oxygen to the tumor. And then the immune system represented here by the T lymphocyte cell. We have our receptor tyrosine kinases on the outside of the cancer cell, and normally they're waiting for their signals to signal through two primary pathways, although again, it's quite simplified. One, the RAS, BRAF, MEK, ERK pathway called MAP kinase, and the other, the RAS, PI3 kinase, AKT, mTOR pathway called PI3 kinase pathway. And we know in tumors, we can have mutations in some of these or rearrangements, as you see down here on the left, RET-PTC rearrangement and NTRK rearrangement. Really key to this picture is VEGF, vascular endothelial growth factor. And its receptor is on cancer cells themselves, but primarily on these endothelial cells. And this is what can do blood vessel growth, new blood vessel growth for the tumors. The drug I want to focus on here, you can see there are many of these multi-kinase inhibitors, is Lenvantinib. And these are primarily VEGF-R multi-kinase inhibitors, but Lenvantinib and others also hit other targets. Lenvantinib hits the fibroblast growth factor receptor and also the platelet-derived growth factor receptor and RET, as we know. And so this is why this is called a multi-kinase inhibitor. It both has some amazing effects, but as we know also, hitting multiple factors, it can have a lot of side effects as well. But I want to focus just a little bit on Lenvantinib to begin with. And then I'll talk next about Pembrolizumab, which is what's called a PD-1, program death 1 antibody that breaks up this PD-1, PD-L1 interaction between the T lymphocyte and the tumor cell or other cells in the microenvironment to cause these cells to be exhausted. But I'll talk a little bit more about that in a minute. So this is really the pivotal trial that got Lenvantinib into use, and it's in widespread use for those of us who take care of these patients with advanced thyroid cancer. And this is one of the most impressive differences that I've seen between drug and a placebo-controlled trial. This was a phase 3 randomized trial called the SELECT trial. 261 patients received lenvatinib and 131 received placebo. And you can see that in this progression-free survival curve that the patients with lenvatinib did much better than the patients with placebo, having a median progression-free survival in placebo of only 3.6 months and over 18 months in lenvatinib. Also, the partial response rate, tumor shrinking greater than 30%, was in nearly 2/3 of the patients. But two caveats. One is complete responses and, quote, cures are very rare, even with a wonderful multi-kinase inhibitor like lenvatinib. And the other caveat is, again, it comes with a lot of baggage. The grade 3 or above adverse events, so these are serious adverse events, was 76% with patients with lenvatinib. So stopping drug, reducing drug, and taking patients off drug, and patients even going to the hospital, was fairly high. So this is a hard drug to take, but we know now how to use it in our patients who need it. So that's just giving a background of multi-kinase inhibitors and lenvatinib in particular. So what about immune therapy? And this you see here, cancer immunotherapy really started becoming used more frequently in 2014 is when it first became approved and used. But I want to back up just a little bit. And cancer immunotherapy has been around for a long time and tried for a long time. And some of the first reports were back in the late 1800s. So really the time between the first use of this and now approval by the FDA was over 120 years. So it's been a long road for immunotherapy, and it still continues to be marching on. So again, just a little history. This is kind of an interesting story about Dr. William Bradley Coley, who I will say was a surgeon. And it seems especially years ago, some of the most disruptive medical doctors were surgeons trying different therapies for their patients where they could not cure them with surgery. And Dr. Coley used what's called Coley's toxins, which was to take a number of bacteria, partially inactivate them and inject them into patients with cancer to try to increase the immune response. And this just shows one man with what was called a round cell sarcoma that he had in his bone here, you see in his face and his abdomen. And he was treated with Coley toxin for a number of therapies starting in 1899. And this shows him later with a nice response to the tumor, although we don't understand the mechanism of this. And Dr. Coley actually presented in 1910, so 11 years later, and said that this man was actually doing quite well with these therapies. And this eventually led, now in 2013 for Science Magazine, to say the breakthrough of the year was cancer immunotherapy. And again, talking about T cells, which is what I want to focus on. There's a whole bunch of other areas we can talk about, but I want to focus on T cells. And this just again is a nice example of T cell based therapies. So one therapy can be the cancer vaccine, which people have tried for years, and that alone a lot of times doesn't work very well, but hopefully can stimulate T cells to attack the cancer. Cell transfer therapy, which is very exciting, working very well in lymphoma and leukemias and blood-based tumors. And now people are trying and finding some success in solid tumors. But I want to focus on the lower one here, immune checkpoint therapy. And to remind us also that we can use this in combination with other therapies, especially what we call immunogenic cell death therapies, such as cytotoxic chemotherapy and radiation, to help boost this effect. So drilling down a little bit more, and this is work, basically, I just want to give a shout out, and I will throughout this, is to my colleague, Dr. Jenna French, who's a PhD associate professor, tumor immunologist here at the University of Colorado, and really has been the driving force behind a lot of this work that we have done. So we have an activated T cell that basically can recognize an antigen presenting cell or a tumor cell, in this case, with this major histocompatibility complex. Here's the antigen and here's the T cell receptor, and it needs co-stimulatory receptors to be activated. Once activated, it increases some of these receptors on the cell surface, such as programmed death 1 and CTLA4. And the reason why they're there is so we don't have an overly robust immune response. And so if we have then the programmed death 1 ligands on the antigen presenting cell, they interact with PD-1 to quiet that response back down. So it's there so we don't have autoimmune disease all the time when we respond to an infection or something like that. And again, two of the main pathways are PD-1, PD-L1, and the CTLA-4 pathway, which I won't talk much about. And so the concept behind these antibodies is to break these repressive features for the T cell. And it can be done through PD-1 antibodies, PD-L1 antibodies, or CTLA-4 antibodies. So again, to get us into this and in toward thyroid, on this, I'll go back to some of the early work in melanoma. And this was lambrolizumab, which actually is the same thing as pembrolizumab. They just changed their name. And this was some early work in melanoma. They always show the patient response. What they always talk about is here's a typical response. I think a lot of times it's their best response, but this is an example of a tumor, a patient with a large mediastinal tumor that had a really wonderful response to just anti-PD-1 therapy alone. Here are liver metastases, very large, that really dramatically shrank. And when they biopsied the tumor, what we see in brown here is the cytotoxic CD8 T cells. And they're fairly low here, but much enhanced with this therapy. So getting kind of this immune response and really a dramatic clinical response. These are patients with melanoma who had been heavily pretreated with chemotherapy, and some had also been pretreated with the CTLA-4 inhibitor ipilimumab. We see a partial response rate that's very impressive in advanced melanoma pretreated of 36%. And a complete response rate even in 1 in 10 patients. So a very impressive response in melanoma, as we know. The other reason I bring this up is these do have side effects. And this is again looking in this large study called Keynote 006. And you can see that any grade response in pembrolizumab of adverse events was fairly high, but that grade 3 to 4 was only 17%, whether you use it every 2 weeks or every 3 weeks, which is what we do now. And remember, it was 76% with lenvatinib. So a much lower grade 3 to 4 adverse events, a little bit higher with ipilimumab, the CTLA-4 inhibitor. We also can see these standard kind of side effects, but one that was very interesting was hypothyroidism. And this was much more with the PD-1 inhibitors than the CTLA-4 inhibitors. And for a number of years, Dr. French and I had been thinking about this yin-yang between the autoimmune response that we see in something like Hashimoto's and obviously the anti-tumor response. And could we use that autoimmune response that we're seeing as an anti-tumor response? The other piece of information that was quite fascinating, and this is from Memorial Sloan Kettering, 48 patients with non-small cell lung cancer, and they looked at patients who all the patients did not have thyroid dysfunction to begin with, but those who either didn't in blue developed thyroid dysfunction or those who did. And the overall survival was better in those who developed thyroid dysfunction. Now, I don't think it's the thyroid dysfunction itself, but it's showing that there can be this immune attack that's unleashed, and in this case being an autoimmune attack. So we really thought about that and how can we study that in patients? And so Dr. French, in one of her papers, looked at these PD-1 lymphocytes, which PD-1 again turns on when it's activated, but it stays on when they become exhausted or not as functional, dysfunctional. And what she found here is either CD8 cytotoxic T cells or CD4 helper T cells. If you looked at uninvolved lymph nodes in patients with differentiated thyroid cancer who went to surgery versus tumor-involved lymph nodes, you see a higher level of these PD-1 positive, either cytotoxic or helper T cells. Interestingly, if you looked at extranodal extension or extranodal invasion, if you had no invasion in the lymphocytes that had that, you had a lower PD-1 CD8 T cell, but in the ones that did have extranodal extension or invasion, we had a higher level of these PD-1 positive, possibly exhausted T cells, which actually Jenna had gone on in a number of other papers to show that these are at least partially exhausted. So it looks like these therapies could be useful in patients with advanced differentiated thyroid cancer. She also found that these cytotoxic PD-8 positive T cells, they had higher PD-1 positive T cells if they had this other cell type in there, a FOXP3 or T regulatory cell. So this creates an immune suppressive environment. So the higher we see this PD-1 or possibly exhausted T cells, we do see these T regulatory cells. So there seems to be this exhausted environment in these patients with more advanced thyroid cancer. So what about these therapies for patients? And this was a study published in 2020 that looked at just PD-1 blockade alone with spartalizumab, another PD-1 inhibitor, in patients with anaplastic thyroid cancer. And now I'll introduce people who aren't as familiar to a swim plot, a swimmer's plot, or a swim lane plot. It's called a number of different things. On the y-axis, you have individual patients. You see the numbers here. This is 42 patients in this study. And on the x-axis is duration of exposure, or how long they've been on the therapy. And you can see at the top, some patients have been on therapy for a long time. And the little triangle is partial response, so a shrinkage of at least 30% in these patients. So some patients got a really good response, and the black arrow suggests they're continuing therapy at the time of the publication. But we also see some patients who received not really much response from this at all. So there's a wide variety of responses. We try to look at the mutation status in some of these, and this is a BRAF mutant, and it doesn't seem to correlate with response. They even looked at the baseline PD-L1, the ligand expression in the tumor. Less than 1% in many studies is considered negative, greater than 1% is considered positive, the less than 1% is in blue. We do see a number concentrated down here in blue of the poor responders, but we actually see some very robust responders in blue as well. So we're looking at this, and many others are still trying to look, and there's probably going to be some integrated group of things like mutations, what the T cells look like in the tumor, PD-L1 expression is going to help tell us how patients respond. But this probably isn't a home run by itself in anaplastic thyroid cancer. And a number of groups, including MD Anderson, have ongoing studies looking at pembrolizumab and lenvatinib together in anaplastic thyroid cancer. What about differentiated thyroid cancer? That's kind of what we're focusing on here. And this was a study of 22 patients with differentiated thyroid cancer, papillary or follicular, who received pembrolizumab as a single agent therapy. And these are patients obviously with advanced progressive cancer. And you can see that the progression-free survival actually is not fantastic. The average is only 7 months. So 7 months from start of therapy to progression. Again, the swim plot we see here, we see some people who had a really robust response and others who didn't have as good of a response here on the right-hand side. And again, what we see is, interestingly, this was a disease progression. You see in the black dots in the top 2 patients here. This is what's called a pseudo progression, because sometimes early on with immunotherapy, you can see the tumor increase in size, but that's because of the immune infiltrate. And so we usually give it a period of 4 to 6 weeks beyond that. And we'll see then some dramatic shrinkage in some patients, as we did in these first 2 patients. And the 2 triangles we see here are the patients that achieved a partial response. Only 9% of patients achieved a partial response. So again, I don't think this is a good single agent therapy in patients with either anaplastic or progressive, aggressive, differentiated thyroid cancer. So we need to do something more. So that really is the hypothesis that we and others have been working with for years, is you have a differentiated advanced thyroid cancer that likely has PD-L1 expression to varying levels. We have our CD4 helper T cells and our CD8 cytotoxic T cells that likely, when they're activated, have PD-1 expression and now have become exhausted. And that's why they can't clear the tumor. We also have T regulatory cells. When they have PD-1 expression, they actually can secrete suppressive cytokines. So they work opposite with that PD-1, PD-L1 interaction. And so we have this generally suppressive tumor immune environment. So if we use anti-PD-1 or even PD-L1 therapy, mostly we're focusing on PD-1 here, we break that and we hopefully can increase that response, but we can see that that alone doesn't seem to increase that response. Using VEGFR multikinase inhibitors such as lenvatinib, we hope to directly treat the cancer itself. And the one caveat I'll say is we've done some preclinical work in many different cancer cell lines. And if you give lenvatinib to just a thyroid cancer cell line, most cell lines you can give a micromolar to it, a very high amount, and there's no direct response on the tumor. There's very rare ones that have certain genetic features that do respond, but most don't. It's probably the immune microenvironment and the vasculature with VEGF that is part of the effect of this, but it could again also be FGF, PDGF, maybe even some RET. But these VEGFR multikinase inhibitors also can suppress T regulatory cells. T regulatory cells have the VEGFR as well. And so that could be this combination we thought would be quite good. And obviously this was combination of lenvatinib and pembrolizumab has been approved in patients with uterine cancer. And so this is FDA approved. And so we started our studies quite a while ago and long before these got approved. And this is the trial I want to focus on for the rest of the time, is an international thyroid oncology group. And again, if you're not familiar with ITOG, I'd recommend you go to itog.org. This is a really wonderful organization that does a lot of multi-center trials in patients with advanced thyroid cancer. And I did this together with, again, my co-PI, Dr. Jenna French, and also Dr. Lori Worth at MGH was our medical oncology co-PI on this study. There were 7 sites: University of Colorado, MD Anderson, Mass General, Memorial Sloan Kettering, Ohio State, UCLA, and University of Michigan. And this was a 2-arm study, not a comparative study, but a 2-arm study in patients who had resist progressive differentiated thyroid cancer. So it had to have progressed greater than 20% within 14 months of enrollment. Cohort 1 is the lenvatinib naive group. So they'd never seen lenvatinib or another multikinase inhibitor. They got started on lenvatinib 20 milligrams daily orally and pembrolizumab 200 milligrams IV every 3 weeks, which was the kind of standard. And this is what the phase 1 trials had said, that we should start lenvatinib at 20 milligrams, not the 24 that it's recommended for in thyroid cancer. They were followed for up to 2 years. And cohort 2 are patients who were on lenvatinib but progressed. They tolerated lenvatinib, but now we had progression, and we're seeing this farther and farther out. Lenvatinib works very well, but eventually patients do progress. They stayed on their daily dose of lenvatinib and added the pembrolizumab 200 milligrams IV every 3 weeks. We enrolled fully to 30 patients in the cohort 1, lenvatinib naive. The primary endpoint here was complete response because there was such a great partial response with lenvatinib alone in these patients. And then we enrolled 27 patients and actually stopped, partly because we had enough patients for analysis, but also because COVID hit. And so we had 27 patients. Here, our primary endpoint was overall response, which is complete response plus partial response in these patients, since they were progressing on lenvatinib. So I'll start with a patient that we saw at the University of Colorado, who was a female with insular, poorly differentiated thyroid cancer. She'd had a thyroidectomy, neck dissection, radioiodine, and unfortunately, before she came to our clinic, she was lost to follow-up. She was a teacher and just didn't end up coming back after this initial therapy and started having this tumor grow to the point where she was wearing scarves to school so she could sort of hide this tumor. And she returned with a large neck recurrence and actually fairly large-sized pulmonary metastases. And so we registered her for cohort 1 in this ITOG study. This shows her CT scan at entry into the study, and you can see this very large mass on the left side of her neck. Her vessels are right in the middle of that, so this is not surgically resectable. And this is just a picture of her with this large tumor. You can see her thyroid scar on this here. And after 6 months on therapy, she had a dramatic reduction to response to this combination therapy of lenvatinib and pembrolizumab. And that just reminds me a little bit of that patient we started with who got treated in 1899 and had a good response to the immune therapy. This is now combination therapy. One thing that I'd been interested in coming back to the autoimmune part of this was, could we increase that autoimmune response in these patients? And so we did look at thyroid autoantibodies, and this just shows some of the early work we did in this. We're compiling now the whole cohort. And this was just some patients. We can see on the left-hand side is antithyroid peroxidase at baseline. And after cycle 7, day 1, each cycle was 3 weeks. And we can see that many patients did not have autoantibodies and did not have autoantibodies at cycle 7, day 1. We have one patient that had very high autoantibodies coming in and really not a dramatic response to therapy. But interestingly, of the 2 patients that have positive autoantibodies to thyroid peroxidase and great increase, one of them was our patient who had that really impressive response. The other thing we can see here is that most patients did not have anti-thyroglobulin antibodies, and we know this from autoimmune disease that thyroid peroxidase is probably a better marker of autoimmune disease than anti-thyroglobulin. So the demographics of the patients we see here is about half and half female male in cohort 1, a predominance of males, interestingly, in cohort 2, those who have progressed on lenvatinib. Prior systemic VEGFR therapy, again, you couldn't have it to get into cohort 1, so none had that, but a large number already had other systemic, before lenvatinib, systemic VEGFR therapy. Many of them had sorafenib, but a few had pazopanib. And distant metastatic disease, lungs was pretty even in both groups, lung mets, and same thing as brain mets and bone mets. But what was interesting here to me, and again, I don't know if this is real or just a statistical fluke, is that no one in cohort 1 had liver metastases. But a third of the patients in cohort 2 who progressed on lenvatinib had liver metastases. Now, does that mean that patients who are treated with lenvatinib, when they fail, they have a propensity to get liver metastases? Or is it that those patients who have a propensity to get liver metastases end up failing on lenvatinib? I don't know, or it could be a statistical correlation, but it is a large number of patients who had liver metastases, so something we could follow up on. So now I show you a waterfall plot of the individuals with their response, and this is in cohort 1, the lenvatinib naive group who got combination therapy. And we can see again, this patient on the left-hand side, their best response was progressive disease. We had some patients with stable disease, but a majority of patients in green here had a nice partial response to this combination therapy. We didn't have a lenvatinib alone or pembrolizumab alone arm, and we know that pembrolizumab as a single agent really didn't have, they only had a 9% partial response. How does this compare to that SELECT trial? And again, this is apples and oranges a bit because these are 2 different studies, but just as a rough comparison, we did not have any complete responses. So our primary endpoint was not met. So this combination so far, at least in this study we did not show a tremendous amount of complete responses. We were hoping for at least 15%. We didn't see it. We saw a very good partial response rate, good stable disease. These are people who are clearly progressing, but not a lot different, at least in this, when you're looking at partial response with the lenvatinib alone trial. Again, these are 2 different trials. What about progression-free survival? Well, again, we had a very good progression-free survival. We've still not met our median progression-free survival, but the 12-month progression-free survival, 80% of patients made that. 18-month progression-free survival, 63% of patients made that. How does that compare to the SELECT trial? What we see here is each time point in the SELECT trial in red, in the red star, and they're less, they're below this, but we don't know if it's statistically significant or would this be biologically significant. Even if it is, it's not a tremendous response difference like we saw between placebo and lenvatinib in that study. So then we looked at the swim plot, the individual patients, and this again shows patients on the y-axis, each patient, and then the months on treatment on the x-axis. And again, like we saw in others, we see a fair number of people who had really pretty robust, durable responses. Some with the forward arrows even continued on treatment after 24 months, 2 years. We can see when they achieved their partial response in the black boxes. So some achieved it early, some achieved it later. This patient number 2 didn't even get a partial response. They were stable disease, but a very durable stable disease. And if we look at the bottom, we see a number of patients who didn't, have very good responses. Some, the X's, even then ended up dying from their disease. When we looked at the type of tumor, we look up here and we see, well, there's a couple Hürthle cell tumors in red up toward the top. That looks good, or a poorly differentiated carcinoma at the very top. This is our patient. But we see some poorly differentiated patients who didn't respond so well and some Hürthle tumors that didn't respond well at all. So we don't think the tumor type is predictive, but we're looking at the analysis of that. So what we're trying to do is now study some of the correlates and say, who are these folks up here and who are these folks down here? And can we predict who may have a better response so we could use this therapy in selected patients? I don't think this is going to be a therapy we can use in all comers. And just to show you a little bit of the correlative work we're doing, this is a standard thing we always do, is look at PD-L1 expression in the tumor. And less than 1 is considered negative, greater than 1 is considered positive across many studies that we do here. And what we see is the progression-free survival is not different between the two groups. So PD-L1 expression in the tumor alone is not a predictor of who's going to respond and who's not. Then we looked at thyroid peroxidase antibodies. This is at baseline, the ones who are negative versus the ones who are positive. And again, we do not see a response. We did look at the response to therapy, increased thyroid peroxidase antibodies, and so far, again, have not seen this as a predictor of who's going to have progression, good long progression-free survival. So this just shows that we're using peripheral blood, and Jenna's doing a lot of work on looking at myeloid cells, on looking at PD-1 positive CD4 cells. And this Ki67 is a marker of proliferation, and to sort of see, are they active proliferating cells? Maybe that's the difference in the PD-1. So we look at a number of peripheral blood markers. We're looking at the tumor itself to see if we can see some sort of an immune response that predicts who's going to respond and who's not. And then we just got data back from collaborating with Yuri Nikiforov using ThyroSeq version 3 to look at the mutation status of the tumors to see if we can get any ideas of response there. So what I want to do here before I wrap up with cohort 2 is just talk a little bit about some of our preclinical work that we're doing to try to dissect out who may respond and who may not. So what Jenna has done together with Dr. Bruna Bertol, who was a visiting graduate student from Brazil, is to use this transgenic immunocompetent model that we got from Dr. David McFadden at UT Southwestern that has the BRAF mutation and P53 knockout. So this is really kind of one of the classic dyads in anaplastic and poorly differentiated thyroid cancer. And then what we use a CRE that's only expressed in the thyroid under the thyroid peroxidase promoter. And then we can turn it on using tamoxifen. So this is also temporal, where we can turn it on. And what we generally do is when mice are 6 weeks old, that's time 0, is we inject tamoxifen to turn on the oncogene and knock out P53. And then we let them go 14 weeks to get tumor development. And they usually have a differentiated and some early anaplastic at this time. And then we treat them either with the anti-PD-1 antibody, Lenvantinib at high dose, and this is something we got from Dr. Jim Fagan at Memorial Sloan Kettering, is this high dose Lenvantinib versus low dose. And if you want to ask in the questions, we can talk more about that, but we think there may be something with this low dose Lenvantinib, and then the combination with the anti-PD-1 antibody. So if we look at primary tumor size, when they first started getting treatment at 14 weeks, we see the size of the tumors here. There's some variability, but the control tumors continue to grow. Anti-PD-1 does not seem to have a great effect, which is what we see in patients. Low-dose Lenvantinib does have a good effect, which is what we see in patients. And actually, it's as good or maybe even a little better than the high dose. And again, that might have to do with the effect it has on the tumor microenvironment. But what we didn't find was this robust combination effect, which again is what we may be seeing in patients. So we think this is a good model to study. They get lung metastases, and we didn't really see a decrement in lung metastases with this combination therapy. And also survival. We didn't see an improved survival. So this may tell us that this combination alone may not be the home run hit in patients with poorly differentiated and anaplastic thyroid cancer. But what they found, which was kind of interesting, was these clones, and this is T-cell receptor sequencing. And so what you're looking at is you're saying, okay, are there ones that are greater than 1% of the population that may be targeting the tumor, maybe a robust response? So the higher number of those clones, and this is in the vehicle treated group up top and the Lenvantinib treated, the combination treated group on the bottom. I'm sorry, this was Lenvantinib. No, sorry, combination. Combination therapy, the higher number of these clones, which could be a productive immune response against the tumor, the smaller the tumor. So even within these mice that are inbred, obviously the T cells still can be different because we have T cell rearrangement once they're adults. So there may be something about looking at these specific T cell responses and specific tumor-associated antigens that Jenna now is working on to see if we can tease that out to predict who may respond. So to finish up in the last few minutes so we can have a discussion, I want to talk about that second cohort, the patients who are on lenvatinib and who tolerated lenvatinib but progressed. So these are all patients who are progressing on lenvatinib. And again, you see by the waterfall plot, many of them actually had stable disease as their best response. One had progressive disease here in red. And then in green, there were 4 patients who had actually a quite impressive partial response. So even in patients who progressed on lenvatinib alone, when we added pembrolizumab, they had a very progressive response. This patient had a 75% shrinkage of their tumor. What about progression-free survival? Again, fairly good progression-free survival in patients who were progressing on lenvatinib. Average progression-free survival was 11 months. So in a way, it bought them 11 months without having progression. Nearly 50% of the patients had 1 year progression-free survival and 30% had 18 months. So there is some durability to this in some patients. So finally, we have the swim plot, and we again see some patients who had quite robust responses. And interestingly, again, these red were Hürthle cell tumors, but you do see some down here, Hürthle cell tumors, that didn't have as robust of a response. So I don't know if this is a tumor type response that we're seeing here. But we see this good responses up top and some less good responses down to the bottom. The X's again are patients who ended up dying. So these are patients who progressed on lenvatinib and did a number of them go on to die from their disease. So this is a pretty aggressive disease. But what we're working on now is to say, who are these folks? Mutation, looking at the tumor microenvironment and looking at peripheral blood responses. This may be a help that we can use, that instead of having to biopsy tumors, we can look at the peripheral blood. And then how are they different from this group? So that's the work that's ongoing now and writing up the manuscript for these 2 groups of patients. So this could be a viable option for patients who progress on lenvatinib. Now remember, cabozantinib is actually approved for these patients. And if again, we look at this versus cabozantinib, don't know if there's a striking difference where this is better, but if we can tease out the subset of patients who really respond, this may be a good therapy in that subset of patients. So with that, I definitely want to thank Dr. French, who's been my research colleague for a number of years now and has really pushed a lot of this research forward. Lori Worth, obviously we talked about. Dan Bowles is our medical oncologist that I work with. Amanda Legreca and Nikita Pozdeyev are 2 endocrinologists who help us with this type of work, and Madeline Kane is a medical oncologist. And then ITOG, really I want to thank ITOG for this, and obviously Eisai and Merck for their support. And then these are the principal site investigators for the ITOG study. So thank you very much for your attention, and happy to answer any questions.
All right, thank you very much. That was really a spectacular talk here. And I'm going to invite Mike Tuttle to join us here and see if we can get some critical questions answered. First one I wanted to just bring up here is this differential response between the primary tumor and the lung metastases that you identified. Do you have any insight into makes those metastases different in terms of response?
Yeah, I mean, the one in our animal model you're asking about.
Correct.
Yeah. So far we don't. What we did was to look at whole kind of like just whether they had Mets or not at this point. We're actually doing some work to try to tease out, because what's hard to do in mouse lungs is to get a tumor burden, a really good tumor burden estimate. So it was just a yes, no at this point of having lung metastases or not, and not tumor burden. The other thing that's pretty fascinating about this model is most of the metastases are differentiated thyroid cancer at this point. They're not anaplastic. And so we probably have to go a bit longer with this model to look at the anaplastic Mets. So I think we need to kind of improve the model before we can start teasing out if there are differences in the shrinkage of the primary tumor and the distant metastases themselves. But we're working on that. And I don't unfortunately have a good answer at this point.
Okay. Mike, do you have questions for Bryan?
Yeah, Bryan, I'm just from a clinical perspective in terms of for the audience to kind of see where this fits into your paradigm. Because now we see people with generally still structurally progressive RAI refractory, but we've got FDA approved drugs first line, we've got second line now. We've got clinical trials. And, so in the average 55-year-old RAI refractory, pulmonary metastasis, how are you sequencing what you're doing with those guys? Trials first line therapy first. How are you guys sort of organizing how you put those options together for a patient?
Yeah, no, it's a great question, Mike. And obviously even you know the answer to that. That's what, at least what you do, and you do it very well. But what I'll say first, coming back to those trials, at this point, obviously they're not approved they're only approved for patients with uterine cancer. And they're probably going to get other approvals soon. But they're not approved, so we don't have them in our clinical paradigm. In the future, I don't think we're going to use them up across the board in anybody. We're going to have to find that subset where they may respond. That's where we could have help there. Then backing up from that, obviously what I do is, and I think you do as well, is these people who are progressing and need systemic therapy, one of the first things we do, if they haven't had it done already, is sequence the tumor. Because these, what are called kind of more second generation, such as the RET inhibitors, NTRK inhibitors, those even ALK inhibitors, we try to get them on those because we know they're as effective as Lenvantinib, even though they haven't been compared head to head, but the toxicity is much better in those. So we try to get patients on those first. If they don't have a mutation that has a focused targetable drug, then what we do is we consider the first line drugs such as Lenvantinib or Sorafenib in those patients. So that's how we do it. And we can't really use immunotherapy in thyroid cancer. Caveat I'll say, obviously, is if you are sequencing, you can do tumor mutation burden and microsatellite instability. And if those are positive, it is FDA approved for any solid tumor, including thyroid, to use pembrolizumab. Again, I don't know if that's effective in that subgroup, but it's something that we could consider even as an FDA approved therapy.
I've also tried to figure out, right, when we first heard about these immunotherapy drugs, and a lot of the early stuff was done here at Memorial, we quickly began seeing all the hypothyroidism in the melanoma patients. And I had this great hope that if we were killing normal thyroid, that really ought to work in thyroid cancer, right? It's one of the side effects. It's the marker. Any idea how you can sort of leverage either how or why the immune environment, these drugs are killing normal-ish thyroid cells and yet not thyroid cancer cells? Any kind of, it seems to me there ought to be some comparison we could make in there to help us understand the differences, but I don't understand anything about immunology. But have you thought about those sorts of things?
Yeah, Mike, I mean, that's what got me into the area. I had the same thought you did. I looked and I said, wow, they're getting all this autoimmunity, and these are still in differentiated thyroid cancer. They're still thyroid cells, so let's unleash it on these cancers. Obviously, it's not as simple as that. So my next level was, I bet it is those autoantibodies. If we'll use those as a surrogate, and the people who get the autoantibody response, like that one dramatic response patient I showed, but so far that's not yet panning out. So it's probably, unfortunately, more complicated than that. And we think of cancer immunotherapy and autoimmunity as two sides of the same coin. But there are differences kind of in those responses. So I think we might be able to use that to our advantage in a subset of patients. We just unfortunately don't know who they are yet.
I mean, you'd love to be able to find some signature that says this is why we get the autoimmune signal, either in the cell or the microenvironment, and then look in the cancer patients that still had that same sort of biomarker or signature either in the tumor or in the bloodstream, right? To maybe help you identify what subgroup that would be, because it's not like everybody gets hypothyroidism when we give them immunotherapy, right? That's it's a subset of those folks.
And it's not only the patients who also already have autoantibodies. That 15% of the general population who already has autoantibodies. That's not the answer either. So some people are using RNA-seq to get these immune signatures.
Yep.
It's cool, but it's pretty crude still at this point. But it is an interesting way to look at the immune signature and say, is the immune signature going to help us?
Hey, Bryan.
Oh, go ahead, Mark.
Yeah, Bryan, I was really fascinated by your comments regarding the underlying T cell variation or changes for patients who had, or in those lymph nodes who you identified extranodal extension, that these were exhausted T cells. Can you elaborate a little bit on that and what you think is behind that? Is this is it an inherent challenge to the immune response, or what's at play here, do you think?
Yeah, I think the simple answer, Mark, is that, again, these really big, we've even shown it with lymph node size, these really big lymph nodes and extranodal extension, which we know from work Mike and other people have done, is those are risk factors for having, higher level of recurrence, kind of more aggressive disease. What we tend to find is you have more PD-1 positive CD8 cytotoxic T cells and CD4 helper T cells. So there definitely seems to be a correlation there. What we have to be careful about is just having PD-1 doesn't mean it's exhausted, because again, that's an early activation marker as well. So that's where Jenna's trying to go back and look at things like proliferation, Ki67, to see which of these cells truly are exhausted. You can look at interferons and interleukins in the microenvironment to say, is this an exhausted microenvironment? So PD-1 is a crude measure of what could be exhausted T cells, but I do believe there's in other words, I think there's an association between the exhausted T cells and that, because you think about that lymph node, it's like going into a castle. You put yourself in a Trojan horse, go into a castle, and then you got all these people in the castle who could kill you, and somehow you've convinced them to leave you alone. And that's kind of what's happening, I think, in that lymph node. Do we know the mechanisms yet? No. But we can definitely study that. Unfortunately, our mouse model, they don't get a lot of lymph node mets, so we can't study the lymph nodes in our mouse model. I wish we could, but don't have a perfect answer for you. But I think there's a strong correlation there, and I believe that there's something in that immune microenvironment that is creating those cells to become exhausted, whether it's the T cells, the T regulatory cells that come in, or something else, and then that allows the tumor to continue to grow, to have big lymph node mets, and to invade. It allows them to invade, might even help them. We've seen in some instances where the immune system even not only allows the tumor to progress, but may create a permissive environment for things like invasion.
Great. And as a follow on there, do see clinically very large lymph nodes, but the absence of extranodal extension. So there's got to be something that allows it, that Trojan horse to find a favorable environment within the lymph node where the cells can proliferate but don't break outside the lymph node into the outside environment here. And so there must be some differential here that promotes extranodal extension versus just progression within the boundaries of that lymph node.
No, you're absolutely right. And we see the opposite too. We see ones with have relatively small tumors in the lymph node, but do have extranodal extension. So again, and that might be something intrinsic to the cancer cell itself. I don't know, but we definitely see that. I must admit, with patients who have tons of involved lymph nodes, especially in older patients, amazingly young patients can have tons and tons of involved lymph nodes, big lymph nodes, but not necessarily a lot of extranodal extension. But you're right. It's not a one-to-one correlation, tumor size and extranodal extension.
Great. Mike?
Bryan, you touched on this concept of low dose versus high dose lenvatinib. I'm hearing it at all the lab meetings and combination. As a clinician, as an endocrinologist, lower is better. I know as an oncologist, higher is better. So can you touch a little bit about what you guys are thinking about in terms of how this low dose and combination, why that topic's even coming up, Bryan?
Yeah, and again, I'll give credit to Jim and his group for really getting us onto this. The concept, and it hasn't been totally proven, but there's some data that supports it, Jim and others have, is that high dose probably is really targeting the vasculature. And what it'll do is it'll basically try to choke off the vasculature, and maybe it's not 100% successful. And that's why sometimes they'll progress through it. Whereas the lower dose may be targeting the microenvironment a little bit more and actually improves the vasculature, which seems weird, but improves it such that you can get your immune cells in there better. And maybe then works on that microenvironment and works on the immune cells and works on other areas of the microenvironment with a lower dose. So you're sort of improving. You're not, because again, I would have thought, let's just choke off the blood supply. But what you're doing is you're probably improving it so you can get more of those immune cells in, and which Jenna has found. And I think Jim's group has found that as well. It looks like you have a more anti-tumor microenvironment with the lower dose than you do with the higher dose.
Bryan, can you just extrapolate a little bit or talk a little bit about the shortcomings of the mouse model that you used? I thought it was absolutely fascinating in reading that study. But can you tell us a little bit about some of the challenges of extrapolating from the mouse model to humans here?
Yep. Yeah. No, there always is. And the number one is it's a mouse. And mice are different than humans. And so that's the case. Obviously, it's transgenic in the sense of you're at some point turning on, and we're turning both on BRAF and turning off P53. I don't know this for sure, but I think it's more sequential in people. I think you probably, in some people, first acquire the BRAF, then maybe get a TERT mutation, and then maybe get P53 later. So it's probably different than that from the human. And one of the criticisms we've actually had in some grants and some other things too is that this is, again, a low mutation burden tumor because it's got BRAF and P53. Now, the counter we usually have to that is if you look at anaplastic thyroid cancer, which we did in a study of large number of anaplastic thyroid cancer versus advanced differentiated thyroid cancer, the anaplastics definitely have more mutations, but not a lot more. And they have a whole lot less than melanoma, lung, colon. So I don't think that's as valid of an argument that, oh, you know, it's because what people have argued for a while is melanoma responds really well because it has a high tumor mutation burden. If you look at colon cancer, it has an incredibly high tumor mutation burden and responds poorly to these agents. So I don't think that's the answer either. So, but that's another kind of criticism. That's a valid, it is a valid criticism that we have. And we're actually doing some studies now because our mice get both differentiated and anaplastic in the same thyroid as some people do. And so we're now trying to use obviously big data techniques like RNA-seq to understand what that transition is, because we didn't do anything different. It's progressing on its own. So we think that's another advantage to study these, but the immune response is, again, not exactly the same as humans. These are inbred mice. There are a number of challenges, but I think what's fascinating, and Jenna got me onto this, I wouldn't have thought, I think they're exactly the same. So the T cell response should be the same. But those T cells do get rearranged. The genetics of the T cells do get rearranged in adulthood. So they're actually a little bit different. So we can study why some respond better than others. So I think that's an advantage we have.
Great, thank you. Mike, do you have any other questions or comments?
Just one last question for the education of the audience. I think, Bryan, most of us are familiar with sorafenib and lenvatinib, but maybe not so much about cabozantinib. Can you just say a word about that approval and where that is, you know, outside of experimental trials, where we are with cabo right now?
Yeah, so cabozantinib is another VEGF or multi-kinase inhibitor that actually in our field started being used in medullary thyroid cancer because it also does hit RET. Another thing it hits that's pretty unique to others is MET. And so that may have some real advantages as well. But there was a trial led by Marcia Brose that looked at this as second-line therapy for patients who'd been on other multi-kinase inhibitors. Most of them, I think, were on lenvatinib, but I think they'd been on sorafenib and some others. And actually, quite a good and durable response to patients who failed lenvatinib. So currently, if you have a patient on lenvatinib and they progress, it became FDA approved this past year in 2021. And you can use that. It's FDA approved, so you get it covered by insurance, and you can put them on cabozantinib, and they do see some quite good responses and durable responses. So that is really probably now moving into the standard as a second-line therapy.
Bryan, thank you. Mike, thank you very much for your comments. Can't thank you enough, Bryan, for just an absolutely outstanding lecture. We're up against the 9 o'clock hour, so we do have to wrap this up. I want to invite everybody back next week. Julianne Sosa will be talking about disparities in differentiated thyroid cancer care. So thank you, everybody. Stay safe. I can't wait till I don't have to say that at the end of these sessions, but we're not quite there yet. Everybody be well, and thank you for joining us.
Thanks, guys.
Mark.
Thanks, Bryan.
Yeah, thanks, Mike.